You may have heard about telehealth or telemedicine, but what about virtual nursing?
The model of healthcare delivery is going to change whether we participate in the change or not. And so we really want to be on the forefront of that and help shape what that care delivery model looks like, because we think we're experts in it.
That's Jennifer Croland, Chief Nursing Officer at OSF St. Francis Medical Center in Peoria, Illinois. And I'm Shelli Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. The old school way of providing care for someone in the hospital included their own personal doctor rounding on them while they were hospitalized, and nurses who provided multiple levels of care. Decades have passed since that model of care, and things are far different. It's an evolution that needed to take place if our healthcare system is going to survive and get the patients the care they need and deserve. You've probably heard the term telemedicine or even virtual care, but what about virtual nursing? Joining us to talk about what virtual nursing is and isn't are Jennifer Croland, Vice President and Chief Nursing Officer at OSF St. Francis Medical Center in Peoria, and Brandi Clark, Vice President of Digital Care for OSF OnCall. Thank you both for being with us. This will be a very interesting discussion. So let's start at the beginning, if you will. What is virtual nursing and why did OSF HealthCare decide to adopt it?
Well, virtual nursing is really utilizing nursing resources that are located at a remote location to assist in patient care delivery at the bedside. Why did we look at it? I mean, you kind of covered it in your opening. We really haven't had a substantive change to how care is being delivered in the hospital setting in the last 50, 60 years. I mean, we're working just like how my mother provided nursing care back in the 60s. But our patients are a lot different. They're a lot sicker than they were. You know, we've made advances in medicine. Patients are surviving illnesses longer. They are getting through diseases, and the patient acuity is just a lot higher than what it used to be. Added on top of that, we have had a shortage in nursing in years past. We saw a decrease in the number of nurses that we had after COVID, and it was really the right time. We needed to make a big change in that care delivery model to make sure that we could continue to provide care at the bedside for as many patients. The other reason is that we weren't always getting the quality outcomes that we wanted. So when we look at our healthcare acquired conditions and those things, we needed more help for those bedside nurses. So we really needed to look at what a substantive change to our care delivery model would look like. And that's where virtual nursing came in.
You started as a bedside nurse.
I did.
How has this, when you started thinking about this, what was the first thing that went through your mind from the bedside nurse perspective?
Well, I think I have with having a background in telemedicine, I think I had a different approach. But the first thing I thought of was, sure, there are things that somebody who's remote can do. And so what are those things? And how do we take the work off the plate of the bedside nurse, shift it to somebody who is remote, still making sure that it's an expert at making sure that it's a nurse, but at the same time giving time back to that nurse at the bedside to do things that only a nurse who's present in that patient's room at their bedside can do.
So working to their license, giving them work-life balance a little bit better, and maybe helping to decrease some of the burnout issues that we also deal with. So Brandi, on a daily basis, how does it work?
So if you've done any research on virtual nursing and looking what other organizations are doing, we launched our model not unlike many others. We started with providing services around admission and discharge. So there are, in the admission process, a lot of questions that are asked of patients that, to Jen's point, it doesn't require someone physically laying their hand on a patient or being in the room with them. So there's a lot of the admission that can be done by a virtual nurse, as well as a lot of the teaching and discharge process that can be completed by the virtual nurse. So we have nurses who physically sit in the on-call building, and they are providing those admissions and discharges throughout the day as they come in, both on all of our med-surg units at St. Francis, as well as in the emergency department, because sometimes patients may be waiting a little while for that bed on the inpatient unit. So we're able to perform that admission process while the patient's waiting in the emergency department.
And how does that work? Is it a tablet? Does a nurse, does a tech, does somebody bring it to them? Walk me through the very specific of how it does.
Sure. So we have a couple models that we're testing here. We started with an in-room installed equipment that provides the ability to have a two-way audio-video connection to the patient. That is on 76 beds in 3 units in the hospital. There is still a lot of evaluating that we're doing to understand what does the future of that in-room equipment look like. So for everyone else across the ministry, including the remaining beds at St. Francis, there is a tablet that's brought into the patient's room in and out. So that's a little bit of the downside today, and some of our opportunity for efficiency in the future is really getting to that in-room equipment in all the patients' rooms.
What did it take to get it fully implemented? I mean, it sounds simple. Okay, we decide to do this. We're going to go in and here's this thing. And they're going to ask you those basic, what's your name? What's your birthday? We all know what those questions are when you're admitted. I have a feeling it wasn't that simple. So there's both sides, the nurse side and the patient side of education. Talk about that.
Yeah, well, the technology piece is actually the easy piece, establishing that two-way audio-visual communication. But we really needed to work with the bedside nurses to understand what that workflow looked like from when the patients were brought up to the floor. How were they going to be communicating with the virtual nurse? Because they're now a part of the team, and we don't want to have errors or mishaps that happen because the team isn't communicating well together. So just really kind of working through that process with both our bedside nurses and our virtual nurses, and then going out and testing it. And we initially took only 3 units live, and we learned a lot on those 3 floors. The bedside nurses were very much engaged. We solicited their feedback, and we made tweaks along the way, both from the perspective of the bedside nurse and things that they said, and then from the perspective of the virtual nurse as well. And then once we got that process really honed in appropriately, that's when we really started talking about spread.
So where exactly right now is this located? It's not across all of our hospitals yet, is it?
No. So today the on-call team provides all of the virtual nursing support for St. Francis Medical Center. And then St. Anthony Medical Center has also deployed virtual nursing in their facility. So we have 2 different models in terms of the way we staff the virtual nursing service. So we have a centralized service in Peoria, and then up in Rockford, they have nurses who work a couple shifts a week on the unit, and then they work 1 shift a week in the virtual nursing role. So we were really diligent in making sure that we had the same expectations for workflow and the way that the work is done and the way that nurses communicate with each other between the virtual role and the bedside, and are really testing a couple different models for how we staff that to understand how does it impact our workforce, how does it impact the engagement of our nurses, are there differences in the patient experience? So a lot to learn there.
Because it is important to know, virtual nurses, they still have to have the same degree. They still have to have the same licensure. Absolutely. It isn't like, oh, just because. So that's very important, isn't it? But I would imagine there's nurses who've been doing this for a long time, and maybe they physically can't be at the bedside. This is a great opportunity, I would think, to keep them engaged in the workforce when we know the number of nurses is shrinking. Is that the case?
Absolutely, yes. It's a great opportunity to keep nurses at the bedside longer by potentially reducing burnout. Also a great opportunity to continue to leverage the experience and the value that nurses who, to your point, may physically have a more difficult time staying at the bedside.
Okay, so what are you hearing from them? What kind of benefits are you seeing and hearing from the nurses?
Well, I think right off the bat, it's giving them more time back, more time to do things, again, that only a nurse at the bedside could do. So as we're really looking at making sure that we're attaining 5-star quality, those could be things like, doing teaching with our patients in a different manner. It could be executing on Foley care or giving a CHG bath or a dressing change. I mean, they could be doing anything, but it's giving them that time back with their patients to provide the hands-on care.
Okay. This sounds like you've talked about we've had to work through and we've learned things as we've gone along. So what have been the biggest challenges?
I think initially one of the biggest challenges was just trusting that team. Nurses struggle oftentimes with delegating work. They like to be in control. They like to, check their boxes and make sure that they're doing all that they can for their patients. And so, really they needed to develop a rapport with that virtual nursing team. So making sure that we're trusting each other, that we have good education or communication, that was our first, I think, really big hurdle. Other than getting the tablets in the room.
Yeah, would you agree, Brandi?
Certainly, I would agree. Yeah. So building trust, the communication, and making sure that we built workflows and processes that were going to enable that and foster that team culture, whether the nurse was at the bedside or in a virtual role and located remotely.
So, obviously 2 years in, have you made changes to workflows and some of the processes?
Yes. We've tweaked workflows and changed the way that the nurses communicate with each other to make sure that communication is timely and clear and everyone understands what is happening with the patient every step of the way. We also continue to optimize the way that we use our EMR tool and the way that will help us gain efficiency in the way that we funnel work to the virtual nurses, because there's some manual process in place today until we have that Epic workflow in place.
Most recently, too, we made some changes to the workflow regarding the discharge process and added in a point where the discharge nurse was calling the transporters so that there wasn't this lag in time after they completed the discharge teaching for the resources at the bedside to call transport. So now they just do that, and that's helping us actually kind of lean down our time and get patients home sooner. They're not sticking around waiting for a half hour or 45 minutes for the nurses at the bedside to identify, okay, their teaching's done and now they can go home. So really trying to take out all the unnecessary time in the process that we can.
So we had talked about at the beginning how you do the admission and the discharge process. So obviously when you're being admitted, the basic questions. But on discharge, you have to make sure they're educated on here's what you need to do, here's what you need to see. So the virtual nurses are handling all of that and walking through it with the patient, correct?
Right.
And then now they're calling transport. So previously, before you tweaked it, you'd have to say, okay, now the bedside nurse would have to come in and call transport. And now it's like, nope, we got it. That seems like a great win. What are you hearing from the patients out there? Because again, it's a learning curve on the nursing side. I imagine for the patients too, at first they're like, who's talking to me? What has that been like and what's the feedback been?
I mean, I think most of what we've heard from patients has been really good. They see it as another member of the team. We really put that out front that, one of our virtual nurses is going to do your admission process. One of our virtual nurses is going to do your discharge process. So to them, they're seeing that face-to-face, two-way audio visual with the nurse across, the screen from them, and they don't have any concerns.
We also are looking at a few key questions on our patient experience survey that really hone in on the work that the virtual nurse is doing. So to try to broadly say what is the impact we're having on patient experiences is difficult. There are so many things that impact that. So we've identified those few key questions in that discharge process that we can tie back to the work that the virtual nurse does. And we are seeing, gradual increases in some of those key questions.
Well, you mentioned it at the beginning as well, that patients are different these days, their level of what they need. So they've kind of gotten used to some of the technology and their smartphones and talking to their grandchildren or whomever through that. So that probably does help with the comfort level for some of them.
And if we have a patient who doesn't want the virtual nurse to do their discharge, I mean, the nurses at the bedside could still do the discharge.
Okay.
But we're really trying to, as much as we can, free that nurse up to do the things that, again, only a nurse at the bedside can do. And so, a lot of times it's just talking through with the patients, tell me why you're concerned, and if we can alleviate some of those concerns, we will.
Okay, so we did ask our clinical staff to submit questions for this podcast, and we did get a few takers, so I'm going to throw those questions out to you. We had one who would like to know what impact the virtual nursing has had on the throughput and 30-day admissions, because 30-day admissions are a big thing that hospitals get rated on and, ranked on. So what has been the effect there?
Yeah, so prior to starting the virtual nursing process for admissions and discharges, from a discharge perspective, it took us about 3 hours from that time that the discharge order was written until the time that the patient actually left the hospital or left the room to make that room available for another patient. So since implementing that, we're down to 2 hours.
Wow.
And continuing to see declines in that number. So I think from a throughput perspective, we're not delaying care, we're actually making sure that it's happening more timely and making sure that patients are getting home sooner from the time that the discharge order is written. Now, from a readmission standpoint, we haven't seen our readmissions increase with having a change in our discharge process. Education at discharge is very important to making sure our patients aren't readmitted. Do they understand the signs and symptoms of what they need to go home? Are they on the right medications? And so really making sure that the teaching is appropriate is very important, and that it's being done with the expertise that we need it to. So again, we haven't seen the readmissions increase, but we haven't seen it decrease either. And I think that may be an opportunity for us. What more can we do at the discharge process to make sure our patients have a lesser risk of having to come back to the hospital?
Yeah, the next question kind of follows up on that. They wanted you to talk more about in regards to the 30-day readmission. What are you doing to make sure there aren't readmissions due to the discharge process? So what are some of those things maybe we're looking at?
Yeah, so I think how we're teaching, we've always encouraged teaching being done from a teach back perspective, but I think if we have somebody that all that they're doing is discharge education and teaching, right, they develop a higher level of competency than somebody who's only doing it maybe a couple hours a day, or maybe not even that. So I think that those are all things that we can continue to look at. Is there the ability to continue to increase the expertise of those discharge nurses who are doing the discharge process to make sure that they're not going home? And then can we tie that back to very specific 5-star opportunities that we have? If we have an opportunity, for example, with acute MIs and their discharge, if their readmission is really high, maybe we want to do some more focused work around education on the discharge process there.
One thing we've learned in the virtual and digital space, we have really robust quality assurance processes in many of our other areas that we support in OnCall. One of the challenges that we have in the virtual nursing space is we don't have call recordings or the ability to go back and do that level of QA in the virtual nursing team today. But what we do have is the ability to do real-time audits of the work being done. You can have a leader sit in the space where virtual nursing is happening and really hear what's happening around them with multiple nurses at one time. That's much more difficult to do in the hospital at the bedside. So we've developed a really robust QA tool. The team is testing it now to understand how do we identify opportunities to continue to educate, re-educate, optimize our processes to ensure that the care being provided to patients is optimal.
I think that's great, just having somebody eavesdropping, if you will. Is this working? I mean, everybody loves that feedback. Okay, and the last question from our clinical staff regards throughput. They were wondering if it's possible to have a physical room manned by non-clinical staff, if no clinical staff is available, to house patients waiting for things like their discharge education, transportation, or meds to the bedside, those kind of things. Is this something a non-clinical staff member could do while we're waiting?
So we do have a discharge lounge that is staffed by a non-clinical person.
At St. Francis Medical Center.
At St. Francis Medical Center, yes. But the patients there are discharged. So it depends on what they're waiting for. If they're waiting for their discharge education, then they haven't been discharged yet. That actually right now in current state has to happen in the patient's room. It wouldn't be able to happen down in the discharge lounge because from a perspective of the patient, they're still a patient of the hospital and we need to assign them a nurse. And I can't assign them a nurse who's a building or two away. And so, yes, we do have that lounge. They can go there and they can wait for their DME. They can wait for O2 delivery, they can wait for their medications to the bedside to be delivered. They can wait for a ride. But discharge education would need to happen up in the room because there's no nurse down there and the patient's not technically discharged yet. But we may change that in the future. We may decide that it may be worthwhile for us to put a nurse down there and to send the patients down to help throughput even a little bit more.
But a nurse, either virtual or in person, has to do the discharge.
Correct.
Yes.
Instructions. Okay, so that's required. So that makes sense on the throughput and getting them taken care of, because that discharge lounge gets used quite a bit but they've already been discharged from the hospital.
Yeah, and if they're a patient in the hospital, they have to have a nurse that's boots on the ground there with them.
Okay. All right. As we look toward expansion, which I'm guessing it is, I mean, I know we start with the big hospitals when we do some things. Sometimes we start our smaller, but these it started because St. Francis obviously had a huge need to get this taken care of. What does expansion look like from where both of you sit, from the inpatient and the virtual side of things?
Well, from the inpatient side, once we implemented this in med-surg, everybody else wanted it. Choi wanted it, Family Birthing Center wants it, Adult Critical Care wants it, right? And so we've actually started expanding as we've been able to some of those areas. Now, outside of admissions and discharges, I think that that's one of the reasons why selecting the technology has taken as long as it has, what the future technology is going to be, because we're trying to decide what else is it that we're going to have the virtual nurse do? What other tasks can they do from the bedside? What else do we need this in-room technology to do for our teams? And maybe it's not even virtual nursing, but maybe it's ambient fall technology. Maybe it's, two-way audiovisual communications that a family can dial in and do a care conference. So, one of the rate limiting steps has been us trying to decide what all do we think we're going to need to use it for.
You don't want to just short-sightedly go, oh, we need this now. And then 6 months from now, it's like, oh, but I wish I would have.
Exactly. Yes. When we started this endeavor 3 years ago, we were thinking about it from the perspective of virtual nursing, a two-way audio video connection into the patient's room for a nurse. Now we recognize 3 years later the number of vendors out there that are providing this type of technology and all of the other functions and features that are available can be a bit overwhelming. So identifying what are our critical requirements for that hospital room of the future, thinking big, and recognizing that we also need to move. So I think we're close on the selection of our technology for the future, and then we'll rapidly move to deploying that as quickly as possible. We are also simultaneously evaluating the opportunities to deploy virtual nursing across many of our other facilities. So it becomes a little bit of a chicken and an egg question. Do I want to deploy virtual nursing using a tablet, knowing that potentially in-room equipment is coming, or do we want to do those things together? So that's some of the discernment and trying to strategically think about what makes the most sense.
And you've heard me say it more than once. The Sisters of the Third Order of St. Francis are prayerful and planful. While we sometimes would like things to move faster, to your point, Brandi, we want them to move correctly and what's best and safest for our patients. I could see this being a real benefit in some of our rural communities where I have to imagine we struggle getting the bedside nurses. It's hard in our more urban areas, let alone in the smaller, more rural. So there would be a huge advantage to getting this deployed, I would imagine.
Yeah, absolutely. We also have not only nursing, but especially in some of our smaller communities, we have a lot of physician resources, hospitalist resources, and other specialty physicians that are providing care into those facilities, providing consult services and care for those patients. And today, we use telecarts that are brought in and out of the rooms. So when you think about the strategy for this in the future, we're hopefully able to reduce the number of different types of technology that we're using to provide all of the care that patients would need through digital or virtual means.
Wow. Jen, you've been around this type of innovative care for quite some time. It was 13 years ago, the EICU. I feel like that was scratching the surface of what we do now. Why is this so important for OSF and for our patients?
Well, I think there's a lot of reasons why it's important, but the model of healthcare delivery is going to change whether we participate in the change or not. And so we really want to be on the forefront of that and help shape what that care delivery model looks like, because we think we're experts in it. You know, from a caring for nurses or caring for patients from a nursing perspective and from providing digital and virtual experiences. And so we really want to shape what that looks like for the healthcare industry. For our patients, I think it's going to get them the care that they need. It's going to give them, you know, their nurse at the bedside, their physician at the bedside, more time to do those hands-on things, and then give them access to a whole other depth and breadth of resources that maybe aren't in their local community that they wouldn't have had access to in the past.
Brandi, you feel the same?
I do. And I think it'll be critical as we are deploying technology into the way that we take care of patients. We can't just layer the technology on top of an existing care model. So we're being really diligent in thinking about how do we redesign the model of care so that use of those digital and virtual means are woven through the care model and part of it, as opposed to tacked on top of it. I think that's where we'll see the real value.
Jennifer Croland, Brandi Clark, thank you so much. Very fascinating. I always say this to most of my guests who come in. We'll touch base with you in another year or so just to see where things are, because we know it will just continue to grow and evolve, and this will be a fabulous part of that conversation. Thank you both.
Thank you.
Thank you.
And thank you for joining us as well. And remember, you can find all of the OSF Healthcare Accelerated podcasts online at osfhealthcare.org/accelerated.